I can't wait to have Professor Raj presentation,
Okay. Good morning and good afternoon to all the attendees. My name is Aravan Tabarian. I'm oral pathologist practicing in Albers University of Medical Sciences. It's my honor to host today's session. And on behalf of the President of the Congress, Dr. Dunya Sadri, I would like to welcome you all to the first day of international section of the 6th Congress of Iranian Oral and Maxillofacial Pathologists. I would like to thank our distinguished speakers for accepting our invitation. Today's event just wouldn't have been possible without the tremendous efforts of the organizing committee, Iranian Association of Oral and Maxillofacial Pathologists, Islamic Azad University of Medical Sciences, Tehran University of Medical Sciences, especially the Appraise to Raise group. In this two-day event, a variety of interesting topics on oral pathology will be covered. There are international speakers and great number of attendees from different countries. And I guess it's going to be a great day of learning, connecting, and exchanging knowledge. We assume that each lecture will take about 40 to 45 minutes, and we'll have 10 minutes for questions and answers. We try our best to have an interactive session, so may I ask you to write your questions or comments in the chat box, and we'll go through them at the end of each presentation. If anybody has any problems with the audio or with the connection, I recommend to exit in one more time, just connecting to the Zoom platform. And if there aren't any questions or comments, we have a lot to cover, so it's better to begin, I guess. And it's my honor to introduce the first keynote speaker, Dr. Raj Singh, Professor of Dermatopathology at Northwell Health. He's the Associate Chair of Digital Pathology, and he is the founder of Path Presenter, an online digital platform. The title of his presentation is Tools for the New Generation of Pathologists to Enhance Education and Clinical Care. That's an interesting topic to begin with, and we're all eyes and ears. Thanks, Dr. Singh. You may start.
Yeah, thank you very much, Dr. Tabarian, and to the rest of the faculty that have been part of the organizing committee for the invitation. Very honored to speak at this meeting, and I'm going to start sharing my screen. Okay. So good afternoon, good evening to all the people that are attending the meeting, from wherever you are attending the meeting today. My name is Raj Singh. I work as a professor of pathology and dermatology, and also very interested in using tools, technical tools for how do I use them for teaching my residents, my fellows, and for clinical care. And we are going to talk about all the tools that we have created that pathologists can use to enhance education and clinical care. So like just as a disclosure, I'm the founder of Path Presenter, which is an online platform that we are going to talk about a little today in the discussion. So if you look at pathology for the last 100 years, not much has changed in pathology. Like the way we practice pathology has been very, very similar as it was being done 100 years ago, where glass slides are being produced, and then the glass slides are sent to the pathologist. The pathologist will then look at the glass slide under a microscope and then generate a report. And once the report has been generated, the slide will go into storage. And not much has changed in the last 100 years. And there was a lot of issues when we were using this kind of workflow, especially during COVID now. In COVID, when pathologists could not come to the office or they could not go to the laboratories, many hospitals, private practices were not able to give the reports, because this requires the pathologist to be on site. And if the pathologist cannot get to the hospital, they cannot get to the microscope, and therefore they cannot look at the slides. The other big disadvantage of this kind of a workflow is that the pathology report is a standalone report, and it is not connected to the other systems within the hospital. So normally in quite a big, in major hospitals, the patient's clinical record, the radiology reports are all interconnected. But the pathology is not connected, so it's a disconnected data set. So, and once the slides go into storage, it is very difficult to retrieve them to use it for research. So there's a lot of knowledge that is mostly untapped. So now we know that things are changing, and the pathology is now moving from an analog to a digital format. And there are a lot of advantages and disadvantages of when we start moving to a completely new way of practicing pathology. So currently, we were looking at the slides under the microscope, and now with digital pathology, the same slide can be seen on any kind of device. So it could be your iPad, it could be your computer, and even your cell phones. You would even see the slide on your cell phone. And with increasing technology advances, the quality of the slide that we see on the computers is very, very good, and we can actually use it for making a diagnosis and for all the other things that we do in pathology. So you can see the screen size becomes much bigger, and it's much easier to manipulate the slide and do a lot of other things. So what are the benefits now when we start to move from an analog to digital pathology? So it enables the pathologist to now work from anywhere. So you don't have to be in the office. So even in the times of COVID, once hospitals and organizations were able to move from an analog to a digital pathology, they could then continue their work even if the pathologist could not come to the hospital. So there was a lot of workflow efficiency that came into the system. It was very easy to now connect the pathology data to other medical records, so much easier to now do research. And then this allowed a lot of new research to develop, and especially now with the AI-enabled diagnosis, there was a lot of additional things that the pathologist can now offer besides just providing a diagnosis. We know there's a lot of hype about what are the advantages, so I don't want to go into too much details, but we know that people talk about increased efficiencies because now there is no more loss or breaking of the slides. It's much easier to retrieve a digital slide. It is easy to integrate the digital slide to a pathology report, and it allows better communication with the clinician. And when you are looking at a slide digitally, it is easier to make the annotations, easier to take photomicrographs, easier and more accurate digital measurements. Like if you're trying to measure the breast flow thickness or the size of the tumor or the size of a metastasis, it's much easier to make an accurate diagnosis. You can pull slides side by side, so it is much easier for comparison. And then if I need to send a slide to somebody across sitting in another continent, it is much easier to share the slide. So all this can be done with the digital pathology. And when you're discussing the case, it is much easier for the case discussion to happen because now you don't have to be in the same room. if a surgeon wants a second opinion, it's much easier to get a second opinion using a digital slide. And then the AI-enabled diagnostics helps in a big way. So what is required for a digital system basically? So every hospital and organization cannot just go digitally. Like they want to go digital, that there's a lot of work that is involved in going into a digital workflow. You need to buy scanners, you need to buy a lot of software that has to be then integrated into the lab information system. So a lot of work is needed for people to move into the digital world. And then these scanners comes in different sizes. So there are huge scanners that can scan up to 400 slides. And now we have smaller scanners that can even scan like slides that are like 1 slide scanner that you can then attach to your microscope and scan the slide. And then obviously you need a lot of storage, because each of these slides that is produced digitally can be like 250 MB to almost like 5 gigabytes. So there is a lot of storage that is needed either on-prem or on the cloud to store this data. And then obviously the software is needed to view the slides. And then that is another thing that is very difficult to get when you're trying to go digitally. So once you have decided to go digitally, then there is a lot of things that you can provide for clinical care, for education and research. So a lot of consultation services can be provided. You can provide remote diagnosis. All your conferences can happen digitally. Your tumor boards can happen digitally. And obviously a lot of research can be done by building of AI and machine learning tools. But there's a lot of cost involved. So we all know that the world is moving towards digital pathology. We have to like get used to say like looking at cases on the computer, on screens. But how do we do this today? Like we might not have the resources today, like buying a scanner, getting the software, then getting used to like how do you use the scanner, how do you use the software. It takes a lot of time and resources. So if you don't have any scanner today, if you don't have any digital slides today, how do you do it today? Like every pathologist wants to start getting used to like seeing the cases digitally. So you have to like find some resources where you can then do this even without the cost. And that is the reason we built this platform called Path Presenter. So I'm going to show you how to use this platform so that you can start getting used to digital pathology from today itself. Even if you don't have a scanner, if you don't have a digital slide, you can still start getting used to digital pathology, sharing cases, looking at cases, starting to teach using digital pathology even today. So we have built a lot of different platforms that can be used, and these are mostly platforms that are available to use for free. So we have an education platform, we have a data sharing platform, we have a reporting platform, a conferencing platform, a platform to create books, and a platform to use with pharma. And it is completely free. And then we will talk about how to use this platform today actually. So there are a lot of institutions, organizations that use this platform today on a daily basis. And there is not only institutions in the US, but also a lot of institutions outside of the US that use the platform on a daily basis. Almost like 500,000 users in 190 countries that use the platform day in and day out. We have also like collaborated with multiple organizations to create teaching tools, which I will show you today, that you can start using. So there's a collaboration with the ISC, which is the International Association of Cytology, and the College of the American Pathology to create this atlas, which is the URL for the atlas is iac.pathpresenter.net. And you can log into the platform to see cytology slides. We have also collaborated with the WHO for the Blue Books, and all the Blue Books are now available digitally, and they are using the Path Presenter software to like make these books available digitally. We have a collaboration with the Digital Pathology Association to create this platform called DAPA, which is dpa-dapa.com, another free platform that you can use. All you need to do is become a member of the Digital Pathology Association. And any resident or trainee that wants to become a member, it is a free membership. They don't have to pay any dues to become a member of the Digital Pathology Association. They can just go into the Digital Pathology Association website and they can become a member for free, and then they get access to this platform, which is called dpa-dapa.com. A lot of faculty have come together to create teaching tools and material on the platform. So I'm going to show you how this platform actually works. So it's going to be a live demo, which is always a dangerous thing to do, but we'll still go ahead and do it actually. So you go to pathpresenter.net, you can register on the platform. There's no money involved. So once you register, you have a username and password. So with the username and password, you will log into the platform. And these are all the different tools that you're going to see on the platform. So the slide library gives you access to thousands of cases here. So you don't have to have a digital slide scanner or like any slide. All you need to do is go into the platform and you will see all these cases here. You can like search for cases. So if you're looking for any case, let's say you're looking for an ameloblastoma. So if you type in ameloblastoma there, it will pull out the slides for an ameloblastoma if they're available in the library. You can then just click on the case here and it will open up the viewer. So it is all cloud-based. It will open the viewer on your phone. It will open the viewer on your iPad, on your computer, and you should be able to then see these slides. So here you can see the slides here. I'm going to minimize this here. So this is the rotation bar that you can say. You can rotate the slide here. Like this is the rotation bar. For zooming into the slide, you just use your mouse to zoom into the slide. And then for dragging the slide in and out, you just are going to use the mouse. So there are thousands and thousands of slides available here that you can use for your teaching. And they are organized into multiple sections. So if you're looking for any, let's say you're going to do a vesicular bullous, you're looking for any vesicular bullous disorder, and you want to look for a slide of pemphigus, you just type in the pemphigus here and you will be able to find multiple files of pemphigus here. If I type in pemphigus vulgaris, it will open up multiple slides of pemphigus vulgaris. So that is the slide library that gives you access to thousands of cases, and these will also open on your phone very easily. So if I want to open this on your phone right now, I can just like click on this share button here. Let's go here and click on the share button here. And if I open this QR code, you can scan. If you have a phone right now, you can scan this QR code. You can just take your phone out. You take your camera, open the camera on your phone. And then if you point your camera to this QR code, then you will see a link that opens up on your cell phone. And you can then just click on that link on your cell phone and you should be able to open the slide. And then once you open the slide on your cell phone, you can then just use your 2 fingers to zoom into the slide, to rotate the slide and everything. So you can see like it will work very nicely even on your cell phone. Even if you are sitting in the middle of Africa, you don't have to worry about, because internet on the cell phone always works very well. So you should be able to open this slide if you take your camera out right now, and you should be able to open this slide on your cell phone. It's also very easy to share a slide. So if I wanted to share this slide with you, I can just click on the link again on this link here, and I copy the link. And if I put this link in the chat, anybody who clicks on that link should be able to then open the slide here. So I'm putting this link in the chat here. And if you click on that link in the chat, you should be able to open the slide on your cell phone. And you can see that it works pretty well actually. So all these slides are available in the slide library for you to go and like have a look at them. So many people, if they're like trying to like make a diagnosis even on the glass slide, and then they think that maybe this is the diagnosis, they want to see another slide, they will just go into the slide library and they will like type in the diagnosis and they can try to see if they can find a slide there. So that is the slide library. This is another section that is very useful, the high yield cases, that you can go into this high yield cases. These are digital slide boxes. So here you can go into the oral and maxillofacial. Click here. This is created by Marwa. She's a professor of pathology, oral pathology in Turkey. You just enter this section here, and you will see that these are cases that have been handpicked by her for you to like use for learning pathology. So you can open any of these cases. And this can be done from anywhere in the world. You can also, like if you are in the department, you can project this on the screen and you can have a look at this case and try to make up your mind what the diagnosis is. So once you have like looked at this case and tried to make up your mind what the diagnosis is, then you can click on this button called case info, and this will give you the diagnosis. So this gives you the diagnosis, cemento-osseous dysplasia. Then you click on the microscopic features, and she's added all these microscopic features here. And not only like she's added the microscopic features here, you can like, it's almost like she's sitting down and teaching you on a two-headed scope, because if you click on this fibrostoma, you'll actually zoom into the file and show you what she's actually pointing out the fibrostoma to you. If you click on the trabecular bone, it will like she's pointing out that this is the trabecular bone that you're supposed to see here. So all these features are being linked to the slide, the cementum-like tissue, and then it will actually point to the slide there. So you can go into all these cases here and then see these cases and then click on the microscopic features, and then it will actually show you the features on the slide. So this is a very useful tool that you can use for your learning of pathology that is available. And you can see that these have been created by specialists from all around the world. And they have created all these different sections that you can use basically for learning pathology. If anybody is interested to create these sections also, it is very easy to create this digital slide boxes. We can work with the author or the faculty and they can come in online and we can help them create this digital slide boxes. And they don't have to have access to their own digital slides. They can use the slides from the slide library. So all these cases are available in the slide library. They can be used to create this digital slide boxes. If you have any questions, please put them in the chat. I will be able to try to see if I can answer any of your questions. If you're teaching pathology, let's say you are going to teach pathology, then also you can use the platform. All you need to do is go into the My Presentation tool, and then you say you want to create a presentation. And let's say you're going to do oral vesiculobullous lesions. I can create this presentation here, and then I can just import the slides from the slide library. So even if I don't have any of my own slides in the slide box, I can just go to the public library, and then I can type in diagnosis here. So if I type in pemphigus, it will pull out a lot of different slides of pemphigus here. And for the sake of time, I'm just going to pick multiple slides here. I'm not going to go into individual slides, just I'm going to pick like multiple slides here. I could just go in one by one diagnosis and pick those diagnoses here, but I'm picking 5 cases here. I can then put them in the order I would like to teach. So I can like just order the slides like I would do in a PowerPoint. I can drag and drop them and put them in whatever order I need. Update the order. And then I can send this off to my residents or my fellows or even to a conference. So if I'm presenting at this conference, I can then just send this to all the attendees in the conference. So I just use the copy link button. And I'm going to put this in the chat again for everybody to see all these slides. So I'm putting it in the chat here. So if you click on this link in the chat, you will be able to see these slides. So you are able to preview these cases before the actual teaching happens. So you can preview these cases. So what you're going to see is something like this, where the slides are available to you almost like a PowerPoint. So you can click on these slides. You can make this full screen. And then this arrow will allow you to move from one slide to the next. So you can preview these slides before the actual teaching happens. And then when I'm going to like actually teach, I just open my presentation like I would do today, like I just did today, and start teaching it. If I want to add any clinical images, gross images, I can upload a PowerPoint here, and then I can add the clinical images and the gross images. So I'm just going to show you one that I've already created here that has the clinical and the gross and everything there. So this is a presentation there where you can see there's a PowerPoint slide here. There are digital slides here, and they are all associated with one another. And like it is very easy to put them in order by just clicking on the reorder button. And I can like drag and drop and put the PowerPoint slides in with the digital slides. So once everything is okay, then I just use this for my teaching. So when I'm ready, I can just click on the launch button. And then this will actually show me the digital slides and the PowerPoint slides like one after the other basically. So it makes it a very, very easy presentation. So if I click here, the full screen button, you can see that this is a PowerPoint slide. And then if I just keep going on the next slide, I can keep going. And I'm just going to go straight away to a digital slide just for the sake of time. So it allows you to integrate digital slides. You can also integrate, like, let's say you have a DICOM file, like a CT scan or a radiology file. You can also like integrate a CT scan or a radiology file into the presentation. So like here you can see like this is a PowerPoint slide. The next slide is actually a clinical image, or it could be a gross image. And then the next slide is a digital slide. So I can like now zoom into this slide and like start teaching of this digital slide. So it's very easy to like integrate digital slides, clinical images, gross images and everything. You can also create polls. So if I want to create a poll for this slide, I could create a poll here, like what is the diagnosis, and then allow the audience to like answer the poll here. I can also like pre-annotate these slides. So if I want to annotate this slide, I can create the annotation here. So I could just create an annotation here and say this is the bulla here. Save and just create another annotation here. So when I'm just going to say this is the neutrophilic abscess. So when I come to this slide, if I've created this annotation beforehand, so I come to this slide, I can just now go to the annotation straight. So I can just click on the down keys on and go to the annotation straight. So I can find those areas very specifically, very easily to go to the annotation by using my mouse and keyboard. So it's very easy to like add annotations, add digital slides. So, and then once it is done, I can send this again to, like once I finish my teaching, I can then just send this again to all the attendees for them to like review the slides after the presentation. So I copy this link here. And if I put this link in the presentation again here, you will now be able to see this presentation with the clinical images and the PowerPoint slides. So if you click on this link in the chat, you will be able to see this presentation. So this makes it a very powerful way of teaching because you can first put the digital slides together, send them to all your attendees, which could be residents, it could be medical students, it could be all the attendees in a meeting, so that they can preview these cases. And once they have previewed these cases, then you can come in next day, you can add your PowerPoint and then do the teaching. And once your teaching is done, then you can send the presentation again so they can go back home and then look at your presentation again. So it makes it very, very powerful for them to use this platform for teaching, where you can send the cases for preview, then you actually do the review, and then you do a post review. And that is available to them whenever they want to do it. They can do it on their cell phones, they can do it on their computers, they can do it, project this on the screen and do it. So it makes it a very, very powerful way for education. Now, let's say I want to like get a second opinion from somebody sitting in Iran, basically, or sitting in let's say in Dubai, or sitting in India, or sitting in Australia. So how do I get a second opinion? I can then, if I have I need a digital slide, or even if I take multiple images from my slide, I can then go into the My Slide box. And then I will be uploading the file here. So I take the digital file and I upload it here. So I just choose my file. And it will take in file from any scanner. So whatever scanner you have, even if you have like a Grundium scanner, which is a one slide scanner, or you have a microscan scanner, or you have a Philips scanner, or you have a Motic scanner, you can upload any kind of that file here. So once you upload the file here, it will then show up it will show up here basically. So you can then first have a look at your own slide, that what has been uploaded, is it looking good? So now I want to send this to somebody sitting in Australia for a second opinion. So all I do is, once I've uploaded the slide here, I'm going to click on this arrow button here, and I can just copy the link and send, or I can even like take the QR code and send it basically. So if I send this QR code to you, you can like just take your cell phone and then open this QR code on your cell phone. So like even let's say you're sitting in a game or you're driving, you would be able to open this file on your cell phone. So if you take your cell phone and scan this QR code, you should be able to open this file. Or if I send it in the, like a link, like I'm going to send it right now in the chat. I take this link and put it in an email, or I put it even in a WhatsApp message, and I send it to the person, like, so they will go to their WhatsApp message. They will click on this link here and they should be able to open this file and then look at the file. And then like, once they've looked at the file, they will call me back and say, Raj, this is what I think is the diagnosis, or these are additional stains that you need to have basically. So like it will just take like 1 second for you to send this slide to anybody once you have a digital slide, or you can even take photo micrographs and send them. But if you're sending photo micrographs, you don't need this platform. You can then just send them by an attachment in the email. So this is more useful if you're sending these big files that are digitally scanned. So if you have a scanner, you can like just scan this file and then easy to send it across to anybody in the US. So let's say you want to say, get a second opinion from a friend sitting in the US. All you need to do is like upload the file here. Once the file is uploaded, then just take the link and then send the link in a WhatsApp message, in an email or anything, and they should be able to see the file. And the good thing is this is a secure platform. It is a HIPAA compliant. So when you're uploading the file here, it will not take in any PHI. So any patient health information is not copied on the file. So when you're sending this file, the person sitting in the US or the UK or Australia, they don't need to worry about any kind of HIPAA regulations, which is very important for people that are practicing where they're worried about any kind of legal issues. So they will be able to open this file without worrying about any legal issues and then see the file. And they can immediately call you back and then give you their second opinion, so that you don't have to wait for a week or two when you're sending these glass slides in the mail for somebody to give you a second opinion. And you can send in multiple files. If I want to send 3 files, I can just take 1 file, 2 files, 3 files, and then just say click on the share button. And then again, just copy the link and then send all the 3 files basically. So when you send this link, people will be able to see, like if you click on this link again, you can then again click open all the 3 files one after the other. So you can send 1 file, you can send multiple files. If you want to send them in a very closed manner where you want somebody to log in and see the file, then you just put in their email address here. So if you put in their email address here, then they will have to log into the system and see the file. Then it is not available as an open link basically. So that is very easy to do again. So for getting a second opinion, like for getting any kind of opinion from anybody, you can use the My Slide box where you can upload the files. For referencing any kind of file that you are currently if you're making any diagnosis and you want to use this platform as a reference, you just go into the slide library and you can then find any file and use that as a reference. For teaching, you can use the presentation tool. You don't have to have a scanner. You don't have to have any digital slides. You just go into the My Presentation tool. You have like more than 30,000 slides in the slide library, and you can start using those files to create your presentation and start teaching from today. You can also do self-learning using the high yield cases, where you just go into the high yield cases and use the digital slide boxes for your learning. You can also create quizzes and assessments. So this is being used a lot for case of the week, case of the month. So if you want to create a case of the week or case of the month, you just go into the assessments. You say, I want to create an assessment and then give it a title, case of today. They're going to call it case of today. And because it is a case of today, we'll just give it like a 1 case and then create the case. And then you can add your question here. So it could be like, what stain will help in making a diagnosis? And then you can add an image. And again, you can use the public library. So I'm just going to use some slide right now just for the sake of, but I could search the public library if I'm looking for a specific diagnosis, and I could select the case. And then the slide would come up here. And I would say I want to do this as a multiple choice. I could add like a clinical image also. If I need to add a clinical image, I could just go into the slide box and find a clinical image and that I've uploaded and use that one. Or I could go into the public library. And let's say I'm looking for a clinical image of psoriasis. So I'm just going to take any image here right now for the sake of, and I could add the clinical image here. I could have immunostains here, and then I could just add any kind of stains that I would like to add. So S100, add another option, LNA. So I could add as many options as I write. I could add explanation why this is right, why that is wrong. I'm just adding any explanation here and then say which one is right. And then if I need to add some more comments here that why, like what should people know about this diagnosis or references, I could add that here, save. And then I can just publish. And then this would be ready to go online again. So save and then publish. So I'm going to just send you one that is already published that you can actually have a look at. So let's find one here that is already published. So if I want to share this one, once it is ready, I just copy the link again and I can put it in, I can put this URL on Facebook, I can put it on Twitter, I can put it on a website, and people would be able to then click on this link, and then they would be able to do the assessment. So if you click on this link, you will be able to do the 10 questions. This one has 10 questions. You finish that assessment, and then you would actually get your score. You would get feedback of how you did, and everything can be done on the platform. So again, another way to like use this for teaching and like spreading your knowledge around the globe. Similarly, you can do like a group chat where you could like actually do consensus meeting on the cloud. You can do your conferences. So a lot of other things can be done on the platform. And I'm just going to show you another platform very quickly. So this one is pathpresenter.net. Another platform where you can come and create books is called Public. Let's close all this right now. So let's close this, close this, close this. Yeah, this one. So another platform that you can go and look at how digital slides can be used is publications.pathpresenter.net. So you're just going to go into this platform, which is publication. So this is a different one where you'll have to have a different username and password. Again, another free platform where you can just log into the platform, and then you will see some books that have been created here, and you can also create similar books. So in this one, I created this book, which is the DOMPATH book. So you go in here and you can go in and see this book here that has been created by these experts. So we have divided it into non-neoplastic and neoplastic. So if you go into the non-neoplastic, you can go into any of these chapters. And when you go into these chapters, you will see like we have put in all these differential diagnoses here. So you can go into any of these diagnoses here. And for every diagnosis that you go into this book, you will see a digital slide. So you will see a digital slide that you can like make full screen if you need. So you can look at this slide as a full screen slide. You have all the information here that is like linked to the slide. So you can have like almost like, and then you have clinical features. So you'll have clinical images. You will have all the clinical features here. For differential diagnosis, you have slides side by side. So with bullous impetigo versus staphylococcal scalded skin syndrome. And if you scroll down, all the features are there. You can look at all these features here, and they're linked to the slide. If you want to like see another differential diagnosis of bullous impetigo versus pemphigus foliaceus, so if you click on this slide will change, the information will change, and you can then like look at also if you can like go see multiple differential diagnoses. For clinical differential diagnosis, it will show you like different clinical images side by side for clinical differential diagnosis. So if you click on again like pemphigus foliaceus, this image is going to change to pemphigus foliaceus. From the outline within this, you can go to any of the other diagnoses. So if you click on any of the other diagnoses here, you should be able to then go to the other diagnosis. So if I click on pemphigus foliaceus, it will then move to the pemphigus foliaceus. So histopathological features, again, it will show you a slide. It will show you all the features here. So this is another free resource that has every diagnosis that you can see in skin. which is also related to oral pathology. And for every diagnosis, you have like slides, you have the features, you have clinical features, you have everything that you would want to know about the diagnosis. So all you need to do is go into publications.pathpresenter.net, create a login. And once you create that login, all this information is available to you for free to use. No money involved. Everything is created. So everything is created for a web presence. So it can be seen on your cell phones and on your iPads, on your computers. Everything is available everywhere. So I think I'll stop there and then like go for any other questions that the audience might have about how do you use these resources from today itself, even if you don't have a scanner or you don't have any access to digital slides, but it is very easy to just go into these platforms and start using them from today to enhance your clinical care services and to enhance your education, and also for somebody to learn pathology on their own.
Thanks, Professor Singh. That was an amazing presentation, and I myself have registered to the platform Path Presenter, and I have enjoyed viewing the digital slides. And now you perfectly went through all the features, especially the publications and the high yield cases. That was great. Any questions or comments from the audience? We'll be sharing with Professor Singh. For the first step, we have to have a scanner, yeah, a digital scanner.
Like you don't need a digital scanner even if you don't have a scanner, and you can just log into the platform. There are like 30,000 slides there already available freely.
Yes, we can use them. Yes, we can use them for free, but if we want to share it with somebody else for a second opinion or something like this, we have to have a digital slide, yeah?
Yeah, then you need a digital scanner, yes, definitely. Because the whole purpose of this platform is to like, how do you use digital slides for enhancing everything, basically. But again, like for residents and fellows that are like on the platform or our medical students, they like, digital pathology, oral pathology is going to move towards digital, like whether we like it or not, whether we love our microscopes and we don't want to leave them, but there is no way out now. It is moving to digital pathology and we have to get used to it. It is now like let's say you start your practice tomorrow, you are not going to be very comfortable with digital pathology from day one. We are comfortable with our microscopes because we have been using our microscopes for years and years in our training and everything. So similarly, if you want to get used to like working in a digital environment, you have to get used to seeing the cases digitally. So even if you don't like it, it is better to start looking at these cases on this digital platform so that you start getting used to it. So that when this change eventually comes to your organization or to your institution, you are comfortable in using the technology in making a diagnosis or in teaching.
Yes, of course. It's a great tool for all of us, especially when teaching in university without a complete archives of the cases. It's really good. It's excellent. Thank you very much for doing this. We have a question from Dr. Afifi that he's saying that, is this site for dermatology only? No.
No,
you can explain.
Like it is for every specialty. Like you can, it is for every specialty. The 30,000 slides that you have there cover every specialty of pathology. So even for oral pathology, there are quite a few cases there that you can just go in and click on oral. When you go into the slide library, there is a drop-down menu that will give you like all the different sections. And if you click on the oral section, you should be able to see all the oral pathology slides there.
Yes, and you just shared the website pathpresenter.net. It's how you can access to the platform. And any other questions? Is there a lot of high quality digital slides in the platform and we can use, we can learn? That was great. Especially in COVID-19 pandemic, that was a great one. Accessing to this platform without attending the classes, that would be very great.
No, that is the reason it took us so much, like so many people using around the world because of COVID, because you cannot get people in a single room.
Yeah.
You cannot get people on a multi-edit scope. So there is no other way to teach that rather than like using some kind of an online web-based platform that will allow the teaching actually.
Yes, the pathpresenter.net, you can log in and you can have the free access to all the great digital archives.
There is a question, so we have to use the QR. No, you just click on the slide library and then you can like type in any diagnosis. You can go by sections, and the QR code is a useful thing to use for like, let's say you're doing a publication or you're writing a book chapter. Then you can like, and you want to add a digital slide. So what in a publication, you cannot add a link. That link is very difficult to click on a publication because you're reading a book at that time. So if you like scan if you put a QR code in that book chapter or in a publication, then anybody can scan that QR code and open the slide on their phone. That is the main purpose of the QR code.
Yes. Any more questions so far? So if we have the access to the scanner, we can also share our cases for free.
Yeah.
Yeah.
That's true. Yeah.
Very good.
And I'm a dermatopathologist. I'm a skin pathologist. So if you have any questions, my email is skinpathology@gmail.com. It's very easy to remember. Dermatopathologist or skin pathology. So skinpathology@gmail.com. If you have any questions, if you have any issues, just send me an email and I'll try to answer them within 24 hours so that we can like help you out if you have any issues using the platform.
Thank you, Professor Singh. That was a very informative lecture, and we will use this great platform for learning and teaching after this. Yeah. So if there aren't any questions or comments, we will go through the next lecture. Before, I guess, yes, we can share that Professor Singh certificate.
Thank you.
Yes. Thanks for accepting our invitation and thanks for your great lecture, Professor Singh.
Thank you very much. Thank you for the opportunity.
Thank you.
Enjoy the rest of the meeting.
Thank you. Have a great day.
Thank you.
Okay. Our second speaker is Dr. Amir Afrobe. Can we go for the next lecture or? Okay, so we can have a quick break and then we can go for the next one. Okay. Our second speaker is Dr. Amir Afroughe. He is the head of Department of Oral and Maxillofacial Pathology at the University of the Western Cape, Cape Town, South Africa, and the principal specialist at the National Health Laboratory Service. The title of his presentation is HPV-Positive Cancers of the Head and Neck. Dr. Afroughe, please take the floor.
Firstly, I would like to thank the Iranian Association of Oral Pathologists for having me at their annual meeting. The topic of my talk today is HPV-positive cancers of the head and neck. We know that there are two different pathways to head and neck cancer. The one pathway is direct damage to the DNA caused by tobacco-associated mutations, and the other pathway is alteration of the DNA by viral proteins. The human papillomavirus is an icosahedral-shaped virus as witnessed by electron microscopy. It has a very small genome. It consists of a circular double-stranded DNA of 8 kilobytes in size. So it's a very small genome. However, there is a lot of information that is squeezed into the viral genome. The genome of the virus is protected by a viral capsid that is made up of capsomeres, as you can see, namely L1 and L2 molecules. Looking at the organization of the human papillomavirus genome, there are three regions in the genes. We call the early region, the long control region, and the late region. All human papillomaviruses encode four core proteins, namely E1 and E2 that are involved in replication and transcription of the virus, and L1 and L2 that are major and minor capsid proteins. Oncogenic human papillomaviruses such as HPV-16 have additional accessory proteins called E4, E5, E6, and E7 that interact with a plethora of cellular proteins to promote cellular proliferation and immune evasion. This is a very nice table to look at. You can see here that E1 and E2 are involved with transcription and replication of the virus. The E4 oncoprotein destabilizes the cellular network of cytokeratin filaments. So in that way, it plays a very important role in virus release and transmission. The E5 oncoprotein, it stabilizes the epidermal growth factor receptor and therefore results in cellular proliferation. That is why EGFR blocking agents such as cetuximab have no place in the treatment of HPV-positive oropharyngeal squamous cell carcinoma and may result even in worse overall survival and even more cancer recurrence in comparison to chemotherapeutic agents such as cisplatin. The E6 oncoprotein targets the p53 tumor suppressor protein and therefore encourages cellular immortalization and longevity. The E6 also has got a PDZ binding motif site that binds PDZ. And by doing that, it results in expression of cyclin B and therefore cellular proliferation. So the E6 also plays a very important role in cellular proliferation. The E7 oncoprotein targets and degrades the retinoblastoma tumor suppressor protein, that is the brake on the cell cycle. And once the brake on the cell cycle is released, we have cellular proliferation. The E7 also activates the histone dimethylases KDM6A and KDM6B. And as a result of that, we will have activation and expression of P16, which is known as a surrogate marker of oncogenic HPV infection. The WHO classifies 14 mucosal HPV type as high risk, and these include your 16, 18, 31, 33, 35, 39, 45, 51, 52, 56, 58, 59, and recently 66 and 68. As you can see the table on the top, these are cancers that are caused by high-risk HPV, namely cervical, vaginal, vulval, penile, anal, rectal, and oropharyngeal. And as you can see that the HPV-16 plays a very important role in these cancers. Actually, for oropharyngeal cancers, the HPV-16 accounts for at least 85% of all HPV-positive oropharyngeal squamous cell carcinoma. There is approximately 29,000 or 30,000 cases of oropharyngeal squamous cell carcinoma that are HPV positive every year. And of these, more than half occur in United States of America and UK. In fact, in the United States of America and the UK, the incidence of HPV positive oropharyngeal squamous cell carcinoma has surpassed that of cervical cancer. There is significant heterogeneity in the prevalence of HPV positive oropharyngeal squamous cell carcinoma, and this is actually linked to the sexual practices around the globe. Like I said, the highest incidence is recorded in the USA and the UK, where more than half of the cases occur. And then there are areas that have got a very much lower prevalence, such as South India, and also Sub-Saharan Africa, as well as some other countries. There has been increasing incidence of HPV positive oropharyngeal squamous cell carcinoma in countries such as Denmark, and also in the Middle East, Lebanon. So what is the profile of patients with HPV positive oropharyngeal squamous cell carcinoma? In comparison to conventional smoking and alcohol-related HPV positive, in contrast to conventional smoking and alcohol-related head and neck squamous cell carcinoma, HPV positive oropharyngeal squamous cell carcinomas are frequently observed in younger married males, usually below 65 years of age. They are of high socioeconomic status and tend to drink or smoke less and report more oral sex partners. On radiological examination, as you can see here on the PET-CT on the right side, you can see a lot of these tumors are very small, well-defined tumors. However, they present with very large cystic nodal metastases. Secondary primary tumors or local regional recurrences are infrequently seen with HPV positive oropharyngeal squamous cell carcinomas. And this is due to the lack of the field cancerization effect, because HPV, high-risk HPV, transcriptionally high-risk HPV is not detected in the peritumoral mucosa. The HPV positive oropharyngeal squamous cell carcinomas are generally more radiosensitive than your HPV negative oropharyngeal squamous cell carcinomas, and this is actually linked to their unique molecular profile. HPV positive oropharyngeal squamous cell carcinoma cells are more likely to undergo apoptosis due to activation of functional wild-type p53 that is frequently mutated in HPV negative oropharyngeal squamous cell carcinomas. And like we said, the viral E6 and E7 oncoproteins encourage rapid progression of the radiation damaged cells through the cell cycle, allowing them to skip DNA repair mechanisms and further increasing their radiosensitivity. I mean, this is now well established that patients with HPV positive oropharyngeal squamous cell carcinomas have better clinical outcomes compared to patients with conventional HPV negative head and neck squamous cell carcinomas. And this survival benefit of these patients is preserved across nearly all the studies, despite significant heterogeneity in patients' population, sample size, and methods of HPV detection. Gillis and al. Were the first to report a 74% reduction in risk of death from cancer among patients with HPV positive oropharyngeal squamous cell carcinoma in comparison to patients with HPV negative oropharyngeal squamous. And because of this survival benefit, a few years ago, there was a new novel staging system for oropharyngeal squamous cell carcinoma, and that grading system is now integrated into the American Joint Cancer Committee Cancer Staging Manual. Looking at the pathogenesis of HPV positive oropharyngeal squamous cell carcinoma, the tonsillar crypts, we know the lining epithelium that lines the tonsillar crypts rests on a dense lymphoid stroma, and the basement membrane at this level has got a lot of breaks or discontinuities. And because of these breaks or pores, there is movement of the lymphoid cells from the stroma into the epithelium, that's what we call lymphoepithelium. Also, because of these breaks and discontinuities, there is exposure of the basement membrane components, such as heparin, sulfate, proteoglycans, and laminin 5, and these are actually viral entry receptors. So these breaks make it very easy for high-risk human papillomavirus to interact with its receptors, which are basement membrane components. The other reason why there is a high incidence of HPV positive oropharyngeal squamous cell carcinoma is because a lot of the PD-1 expressing lymphoid cells interact with a ligand, PD-L1, that is located on the basal cells. And this results in an inactivity of the lymphoid cells, and therefore, in that way, the HPV can evade the immune system. So the tonsillitis area is actually a very good immune privileged site for high-risk HPV infection. So because of the survival benefit of the patients with HPV-positive oropharyngeal squamous cell carcinoma, the College of American Pathologists now recommends high-risk HPV testing on all patients with newly diagnosed oropharyngeal squamous cell carcinoma, including all histologic subtypes. The testing may be done on the primary tumor, or it can be done on the regional lymph node metastases when the clinical findings are compatible with a primary oropharyngeal squamous cell carcinoma. So the question may arise that what is the ideal test? An ideal test should be highly sensitive, highly specific, it must be practical, inexpensive, and strongly prognostic. We know that there are different testing modalities. One of them is DNA polymerase chain reaction, or the DNA PCR. It's a highly sensitive test because it amplifies even small quantities of DNA. However, it's not specific because we cannot visually localize the HPV DNA to the tumor cells. On the other hand, you have got the DNA in situ hybridization, or the DNA-ish, that is not as sensitive because it does not pick up small quantities of DNA. However, on the other hand, it is highly specific because you can visually localize the HPV DNA to the tumor cells. Perhaps the best test, or the gold standard of testing, is mRNA in situ hybridization. This is because you can visually localize the HPV mRNA transcripts to the tumor cells. And at the same time, the transcription process causes a stage of amplification, and therefore this test is very sensitive. So the RNA in situ hybridization is a very sensitive and a very specific test, and the gold standard in detection of high-risk HPV infection. Back then, when I was in Massachusetts General Hospital and I was a fellow there was a colleague of mine who was a fellow, Dr. Darcy Kerr, and she, for the first time, used mRNA in situ hybridization in detection of high-risk HPV infection. And you can see how beautiful the staining is, and you can really see the red signals that are the high-risk HPV mRNA transcripts in the tumor cells. What about P16? Well, the P16 test, or the P16 immunohistochemistry, has a very high sensitivity, and this has been established in a number of studies. It has a sensitivity of almost 100%. However, the specificity is also very high, it's 90%, but lacks a 10% specificity. But because of its very good sensitivity and specificity, the P16 immunohistochemistry has been deemed sufficient by the College of American Pathologists for confirmation of HPV-positive oropharyngeal squamous cell carcinoma. And also in metastases to regional lymph nodes, particularly level 2 and 3 with a non-keratinizing morphology, P16 is sufficient to confirm an HPV-positive oropharyngeal squamous cell carcinoma. However, like I said, although it has a very high specificity, the specificity is 90%. And outside the oropharynx, the specificity is not so great. We can see that this was a study that we did together with Professor Fred Jacobiak, the late Professor Jacobiak, who is the world eminent ophthalmic pathologist. And we look at periocular sebaceous carcinomas. A lot of these cancers express a high expression of P16, but at the same time, when you investigate them with HPV confirmatory tests, they are negative, such as HPV mRNA. So P16 expression, particularly outside of oropharynx, does not equate high-risk HPV infection. And P16 then can therefore be also be expressed by other mechanisms, for example, mutations of the retinoblastoma protein. This is an example of a P16 expression. As you can see here, it must be positive in more than 70% of the cells, both nuclear and cytoplasmic staining. And on the right, you can see a DNA-ish that shows the HPV signals that you can localize, you can visually localize the HPV DNA to the tumor cells. However, there can also be a lot of problems with the DNA-ish in terms of the background staining. So based on its outstanding performance on the small tissue samples, practicality, and the wealth of literature implicating P16 as an independent predictor of survival in oropharyngeal squamous cell carcinoma, the CAP now recommends high-risk HPV testing by surrogate marker high-risk HPV for oropharyngeal non-cytology tissue specimen. A few years ago, this is the group that was convened a few years ago at the College of American Pathology, and they went on and they gave their recommendations and testing guidelines, and there's an algorithm that I'm sure that you're all familiar with. Looking at the role of high-risk HPV in the head and neck region, we can see that there is a strong association with high-risk HPV and oropharyngeal squamous cell carcinoma in the region of 80 to 90%. In the sinonasal cavity, this is less, and the association of high-risk HPV with sinonasal cavity squamous cell carcinomas is sinonasal cancers is 20 to 25%. In the oral cavity, there is no strong association. It's usually between 3 and 6%, and I will come to that a little bit later. And for the larynx, is less than 5%. Other head and neck sites, where we did a study when I was at Massachusetts General Hospital, we did a study looking at high-risk HPV in squamous cell carcinomas of the conjunctival and the lacrimal sac. And we could, using P16 and PCR, we demonstrated that 30% of these cancers are indeed associated with high-risk HPV. So the periocular cancer could be actually the second site of the oropharynx in the head and neck with a high burden of high-risk HPV infection. And a lot of these cancers were also, like other cancers, or like other HPV-induced cancers, where of HPV-16 played a very major role, a very important role. However, the oropharynx is the only head and neck site where there is strong evidence-based information linking HPV positivity to improved outcome. However, this is not the same for the different parts of the oropharynx. You must remember that. It's usually, the link is very strong between high-risk HPV and oropharyngeal squamous cell carcinomas in the palatine tonsils and the posterior pharyngeal wall. Correction, in the palatine tonsils as well as the base of tongue, and is less stronger for other sites such as the soft palate and the posterior pharyngeal wall. So this may be very important and may have implications for radiotherapy and site-specific targeted therapy for high-risk HPV. The majority of these oropharyngeal squamous cell carcinomas have got a non-keratinizing morphology or non-keratinizing squamous cell carcinomas. Other variants of squamous cell carcinomas in this region that can be positive for high-risk HPV are papillary squamous cell carcinomas, adenosquamous cell carcinomas. Some small cell carcinomas in the oropharynx have been shown to be associated with high-risk HPV. However, despite this association, they stay uniformly lethal, and this is very important to remember that. In the sinonasal cavity, like I said, about 5 to 25% of these carcinomas can be linked to high-risk HPV. There were some cancers that were described, such as carcinoma with adenocystic-like features, or the multiphenotypic sinonasal carcinoma that was first reported by the Johns Hopkins group a few years ago. And also there are some other cancers in this region that can be associated with high-risk HPV. This is a typical morphology of a HPV positive oropharyngeal squamous cell carcinoma. They usually show this lobular growth. The lobules or the islands are made up of these cells that have got these basaloid morphology with a high NC ratio. They present with comedotype necrosis and are associated with a dense lymphoid stroma. And you can see on the other side, the P16 immunohistochemistry that is really strong in these cells, and it stains more than 70% of the cells, both cytoplasmic and nuclear. We do not grade these HPV positive cancers in the oropharyngeal region. We simply just call them HPV positive or P16 positive squamous cell carcinomas. Avoid grading these type of cancers into well differentiated, moderately differentiated, or poorly differentiated. Like we said, some squamous cell carcinoma variants in the oropharynx that can be positive for high-risk HPV. An example is the papillary squamous cell carcinoma. There was an entity that was also described a few years ago by Roger Sithala called the non-keratinizing ciliated adenosquamous cell carcinoma, which can actually mimic your mucoepidermal carcinomas. You must be actually wary of these cancers. They are P16 positive, then they also have a very good prognosis. I just talked very briefly about the sinonasal tract, and we said that a few years ago, there was also an entity called the multiphenotypic sinonasal carcinoma that is HPV related. And this can also closely mimic your adenoid cystic carcinoma. So you must be very wary of this lesion, particularly for the practicing head and neck pathologist. They can have the same morphology as well as the same immunophenotype. They can be positive for CD117, just like your adenoid cystic carcinoma. However, they are negative for the NYB gene alteration that has been demonstrated in adenoid cystic carcinoma. And on the other hand, they're usually positive for high-risk HPV types 33 and 35. You can see how closely they mimic your adenoid cystic carcinoma. They can have a cribriform architecture and they are positive for P16. However, they are positive for P16. And one other thing about them on morphology basis is that they are quite pleomorphic and they usually show surface dysplasia, something that you do not see in your adenoid cystic. So we went on to look at the prevalence because there were no solid studies looking at the prevalence of high-risk HPV infection in the sub-Saharan Africa. We went on to do a study and we practice at Tygerberg Hospital, which is one of the largest tertiary care centers in sub-Saharan Africa. We looked at cases of oropharyngeal squamous cell carcinoma between the period 2007 and 2017. And we went on to do P16 as recommended by the College of American Pathologists, use P16 as a screening test. And the cases that were P16 positive, we went on to confirm high-risk HPV using the BD Viper PCR technology. It was recently published in the archives of pathology, the Journal of College of American Pathologists last year. And we demonstrate a very low prevalence of high-risk HPV infection in our setting, a low prevalence of 5%. The majority of these cases had a non-keratinizing or a partially keratinizing morphology, as has been reported in the literature. HPV-16 was responsible for the majority of these cases. However, we did demonstrate a case of high-risk HPV-52, 18, and 31, which may have an implication in the current vaccination strategies that are implemented in the region. What was very interesting that of the 200 and odd cases that we saw, we had 23 cases that were P16 positive. When we tested these P16 positive cases using PCR, only 13 were confirmed to be of high-risk HPV infection or caused by high-risk HPV infection. So you can see that the P16 did not have a good positive predictive value. Indeed, the P16 positive predictive value was only 36%. This shows that P16 is actually not a good surrogate marker of high-risk HPV infection in our region. And this was one of our findings, and we showed that probably P16 is not a good marker of high risk, a good surrogate marker of high risk HPV infection in low prevalence areas such as ours, and this may influence the CAP guidelines for recommending HPV testing. You might ask, why did you have a low prevalence in your region? We know that oral sex is the most important risk factor for oropharyngeal squamous cell carcinomas. And this may be related to the sexual practices that we have in our region. And indeed, a number of studies in America have shown that, HPV positive oropharyngeal squamous cell carcinoma is predominantly a disease of white race, college educated males. And if we have to take that into account, in our region, a majority of the patients that we had were of African or mixed race descent. Looking at the vaccination or the prevention programs, just briefly, I will touch on that. The HPV vaccine was rolled out in sub-Saharan Africa, and the two main vaccines are Gardasil and Cervarix, and these only cover you on 16 and 18, which is actually great because the majority of these infections are caused by type 16. But as we showed in our studies, there can be other types, and it may be better to use a broader spectrum type of vaccines such as Gardasil 9 that provide a much more broader spectrum against different high-risk HPV types. It may be also better to vaccinate both males and females. I know that in Australia, they have started a gender-neutral vaccination, and for although it is still very early to debate on the results of the vaccination programs, there are some reports that are showing quite effective prevention against HPV-positive oropharyngeal squamous cell carcinoma. So now what is new actually now in the field? It has been shown that a subset of oropharyngeal squamous HPV-positive oropharyngeal squamous cell carcinomas show estrogen receptor expression, and it has been shown that those subsets that show estrogen receptor expression have even a better survival, and there is a lot of research that is ongoing in the area. Another article that was published just a few, possibly a month ago or 2 months ago by James Lewis, was on human papillomavirus associated oral cavity squamous cell carcinoma. We know that the prevalence of HPV positive oropharyngeal squamous cell carcinoma, HPV positive oral squamous cell carcinoma is very low, somewhere in between 2 to 5%. However, no one has conclusively shown the morphology and characteristics of these tumors. And indeed, in summary, this article shows that HPV-positive oral squamous cell carcinomas commonly involve the ventral surface of the tongue and the floor of mouth. They usually have a non-keratinizing morphology, similar to your HPV-positive oropharyngeal squamous cell carcinomas. And they are associated, what is very interesting with them is that they are associated with extensive foci of oral squamous cell carcinoma in situ that has got a basaloid or a boinoid morphology. They all occur in men. In contrast to your HPV-positive oropharyngeal squamous cell carcinomas, they are strongly associated with alcohol and tobacco. And again, in contrast to your HPV-positive oropharyngeal squamous cell carcinomas, they are very aggressive and show a very inferior survival. And most of these cancers actually show positive margins on surgery. So maybe it may have an implication identifying these cancers for the surgeon. So if you see an oral cavity, a non-keratinizing squamous cell carcinoma on a biopsy, or oral squamous cell or an oral squamous cell carcinoma in situ in the oral cavity that has got a boinoid or a basaloid morphology, you can tell the surgeon that this is going to be an aggressive lesion, and they can actually be quite aggressive with their treatment strategies in terms of margins. Again, what I would like to touch on is about 10 to 20% of HPV-positive oropharyngeal squamous cell carcinomas tend to behave aggressively and are associated with local recurrences and distant metastases. So is there a way that we can kind of monitor these patients that present with aggressive disease, or also monitor response to therapy? There was a study that came out not so long ago by the Forden group at Massachusetts General Hospital, and they found out that circulating HPV viral DNA could actually be a very good, specific, and sensitive biomarker of a disease progression and tumor response. If you want to read more about that, there's also a recent article that came out on that, the future of circulating tumor DNA as a biomarker in HPV-related oropharyngeal squamous cell carcinoma, that was written by the James Rocker group. So you can actually read about that, which is going to be the best, I would say, liquid biomarker for a high-risk HPV infection, looking at disease progression and response to treatment. And before I conclude my lecture, this is also very interesting. It just came out a month ago in a letter to the editors. Human papillomavirus associated combined neuroendocrine and squamous cell carcinoma of the sinonasal tract. This is gaining a lot of recognition by the pathologist. It is a cancer of the sinonasal tract that shows both neuroendocrine as well as a squamous cell carcinoma differentiation. As you can see on the right side, it shows the typical large as well as small neuroendocrine cells that are positive for neuroendocrine markers. And then it also shows areas of typical your conventional squamous cell carcinomas that are positive for CK5 and P63. But as a whole, the tumor is positive for P16. And when you test for high-risk HPV, they are positive for high-risk HPV. So it's very important as a head and neck pathologist, as a practicing head and neck pathologist, to identify these tumors, because we can look at these tumors and then look at their, once we have got a very good cohort of these tumors, we can then look at their behavior as well as their survival. And before I also conclude the lecture, this is Boulders Beach in Cape Town, and these are the African penguins. If you do visit Cape Town, I encourage you to visit the Boulders Beach and have a good experience there and see these interesting species of penguins closely. I thank you very much again from the Iranian Association of Oral Pathologists for inviting me and having me here. I really appreciate it. Thank you very much.
Thanks, Dr. Afroga, for such an informative lecture. Thank you very much.
Hi, Amir. How are you?
Thank you very much, Bian.
Thank you for accepting my invitation.
It's good to seeing you, and thank you very much again for inviting me here.
It's a great,
really
great
an honor. Thank you.
The honor is ours to have your great contribution to this meeting and great presentation. I think your presentation was very influential and helpful for the pathologists especially. And if Dr. Etebarian would let me, I would like to ask a few questions from Amir.
Of course, thank you.
Okay, first of all, I think we have Professor Jos with us. Professor Jos, do you have my voice?
Yes, I do.
Great. Thank you very much for being here with us in this meeting. And do you have any comment on great presentation by Amir?
No, it's excellent. I just had a question about those P16 positive oral squamous cell carcinoma, which seem to be tobacco related. Do you think this may be a passenger infection or a co-infection rather than a primary infection? If you look at the histology of those tumors, they have got a non-keratinizing part and a keratinizing part. What is your opinion on that, Amir?
The study that was done by James Lewis, they used P16 as well as they used the mRNA-ish, which is actually a very sensitive and a specific method for transcriptionally active virus. So I think those are truly high-risk HPV-related cases. Like I said, the prevalence, and even they also acknowledge that the prevalence is very low. But again, these 2 to 5%, there are cases of high-risk HPV-associated oropharyngeal squamous cell carcinomas. And these ones have actually got unique characteristics. They have a non-keratinizing morphology with areas of keratinocytic maturation associated with the smokers, heavy drinking and heavier smoking. However, they are not associated with improved outcome like we see in the oropharyngeal squamous cell carcinoma. They even do worse than some of the oral squamous cell carcinomas. Their location is usually on the ventral surface of the tongue and the floor of mouth. And the majority, again, occur in men. So I think they are truly high-risk HPV related because they used mRNA-ish, or mRNA PCR, I cannot recall, that catches the virus in its transcriptionally active state.
Yeah, thank you.
You're welcome.
Okay, great. It means that oral squamous cell carcinoma also should be divided into HPV positive and HPV negative. I am not sure if I get the Professor Hill's point. I have seen a recent publication in the literature that I have included in my lecture. I will present it later, that we have an entity that it is called as HPV associated oral squamous cell carcinoma. Amir, have you read this article published in Head and Neck, I think Head and Neck Pathology journal?
There are a few articles, I'm not sure which one you're referring to, Puyan, but I think there were a few articles from different groups that look at this. Even I know that Professor Mark Lingden also looked at this. these HPV-associated oral squamous cell carcinomas. I think the first person who actually reported these squamous cell carcinoma in situs that are HPV positive was Dr. Sook Bin Vu, if I'm not, but at the time there was not much support for that. And I think James Lewis now went on and did this incredible study. So there is this now, there is, like you said, we can now divide it, these oral squamous cell carcinomas into high risk associated and HPV negative. But like we said, the incidence is very low. It actually may have implications, some implications, because we have shown that these HPV related cancers can be very, very aggressive. And a lot of those, when he looked at it, a lot of the margins in those cancers are positive. So this may have an implication in a way that we can tell the surgeon, look, this might be HPV positive cancer, and they can be more aggressive with these tumors. Yeah.
Okay, and the next question is regarding all cancers of the head and neck region, and regarding HPV positivity or negativity, do you recommend any algorithm to use different techniques to detect HPV? You well explained that we have different techniques to detect HPV, including IHC study and also ISH. Do you recommend any algorithm regarding also the, some of them are very expensive. For example, SISH study is very expensive in most countries, including Iran. Which way do you recommend to detect HPV in head and neck region?
Thank you for the question. So for that, I have to really go with the College of American Pathologists. So they recommend P16 testing only for the oropharyngeal cancers. And they deem and say that P16 would be sufficient to confirm an HPV positive oropharyngeal squamous cell carcinoma. But again, you should be very careful because of the study that we did. The P16 in low prevalence areas may not be a good marker, surrogate marker of high risk HPV infection, and you might like to go on to do another confirmatory test. I think P16 and PCR, a number of studies have shown to be a very good combination. So this is something that you can look at. I'm sure that a lot of countries have got the PCR facilities. So P16 and PCR would be, I think there was a study by the NDI that showed that in a large cohort of patients that P16 and PCR would be a very good confirmatory test. I have had issues, I've used DNA-ish particularly, but the DNA-ish, again, you have problems like background staining and those issues that may be also challenging. And like I said, it's not very sensitive, and it does not really pick up small quantities of DNA. Outside oropharynx, I know that CAP does not really recommend HPV testing. And P16 does not have a very good positive predictive value outside oropharynx. So again, there is a number of cancers there that are being recognized. Those are specific entities like your multiphenotypic sinonasal carcinomas and some lacrimal squamous cell carcinomas. Those ones, again, you can do P16 and you can confirm again, because I said P16 does not have a good positive predictive value outside of oropharynx, you need to do a confirmatory test. So PCR may be the best again to use in this situation, especially like you said in countries where still the mRNA-ish technology is not very well used or employed, and is very expensive. So those are my thoughts. Yeah, I would say,
Okay. Great. And do you recommend any preparation for the specimens which are going to be evaluated for HPV using SISH study, ISH study?
You mean you mean your tissue blocks? Is that what you're talking about?
Is it possible to use the formalin fixed paraffin embedded blocks?
Yes, you can. Actually, a lot of that fish can be used on automated system like your immunohistochemical chemistry platform that you have. You can apply fish there. Even now, a lot of these, the new mRNA issues now being used on the the immunohistochemistry platform, so it can be applied to tissue blocks. Yes, it can.
Is it possible to extract RNA from the tissue blocks? You know, I think it is technically difficult, and I found it very difficult to extract RNA from the formalin fixed paraffin-embedded block. What's your experience?
Yeah, I don't have any experience with mRNA-ish because we do not use the platform here but I'm sure that there are now very much, because I remember when I was at MGH, there was a lot of problems with these mRNA-ish. There was a lot of troubleshooting. It was a very cumbersome process, but now I think it has become pretty much very well used and employed on automated systems such as immunohistochemistry and very easily applied. So I'm sure it can be, it is now, I don't have any experience with it. Like I said, we don't have the technology yet here also, but I'm sure now it is becoming the gold standard all over the world. It's slowly by slowly, yeah.
Okay, thank you, Dr. Etebarian. I think you have several questions.
Yes, there are some in the chat box. Dr. Darakhshan asked that why did you not use IC for P16 evaluation instead of PCR? I think you mentioned about that you first did the P16 and then...
Yeah, so we used, because we said that P16 has got 100% actually sensitivity. So we use P16 as a screening test. If it is negative, we know that high-risk HPV is not present. And if it's positive, we then go on to confirm, yes.
Yeah, for us that is not available sometimes. I think this is the good strategy. Yeah. And any other questions? I don't have any more, but I think the best one is in Iran to design a study to like that you had it in Africa to see that what's the prevalence of HPV positive oral squamous cell carcinoma.
That actually would be good. We can collaborate on that. And very interestingly, like I said, there's an article that came out that Lebanon is actually now having a very high incidence of these HPV positive oropharyngeal squamous cell carcinoma in the Middle East. So maybe it's now turn also for the Iranian group to also look at their prevalence. Yeah.
Of course, and then we can decide that what is the best strategy for the treatment and also for the screening, I guess.
Yes.
That's right. Yes, that was very good. Thank you very much for
your welcome. Okay. Thank you.
Thank you.
Okay.
Sorry, we have more questions from Nasser. We have documented years. I think he explained that we have documented years ago integrated HR HPV in salivary mucoepidermoid carcinoma. I think favored against. I cannot read it easily. Do you have any comments? Do you have any experience with salivary gland carcinoma? Is there any association with HPV positivity?
Yes, we looked at lacrimal gland adenoid cystic carcinomas. And the majority of the lacrimal gland adenoid cystic carcinomas were negative for high-risk HPV. I know there is some reports in the literature, but those reports go back to the days that a lot of these were not confirmed using mRNA-ish and those other technologies. So, I'm not sure how truly these are caused by high-risk HPV infection. I'm not so sure about that. But the experience that I have with lacrimal gland adenoid cystic carcinomas, that they were not truly associated with high-risk HPV infection.
Yes.
Great, thank you.
So if there aren't further questions or comments, we can show the certificate for Dr. Afrobe. And then we can have a short break. Yes, thank you very much.
Thank you very much. Thank you.
For contributing to this conference. And
thank you very much, Amir.
Thank you very much. Okay, great.
Hope to meet you again.
Sure.
So we can have a 5 minutes break, I guess, and then we can continue. Okay, welcome again. And for the last but not least presenter, I would like to introduce a great colleague of mine, Dr. Puyana Amini-Shakib, the Associate Professor of Oral and Maxillofacial Pathology Department, and also Cancer Institute of Imam Khomeini Hospital, Tehran University of Medical Sciences. His presentation topic is From Oral Epithelial Dysplasia to Oral Squamous Cell Carcinoma, Diagnostic Clues and Classifications. This is a very challenging topic, and Dr. Shakib, the platform is yours.
Thank you very much. Good morning, good afternoon, and good evening to all my colleagues around the world. First of all, as Dr. Etebarian explained, that this is a challenging topic, and I would like to invite all the audience to turn on their videos. I hope it would not be inappropriate for them, but I would like to invite you all to turn on your videos, and I would like to invite you to share your comments after each section of my presentation. Let me share. Yes. Okay, it's a great pleasure to have you all, to see you here, and I will try to have a discussion on this important, I think, topic and very practical issue. All of us face with challenges of diagnosis, making diagnosis on oral epithelial dysplasia and also oral squamous cell carcinoma during our routine practice. Okay, let's get started. I am a member, honorably, I am a member of Oral and Maxillofacial Pathology Department of the School of Dentistry of Tehran University of Medical Sciences. We have few cases weekly in our department, but I have very talented, enthusiastic colleagues at my at our department, and they are very eager to make research and also make diagnosis on challenging cases. Also, it is a great honor for me to be a member of Cancer Institute Hospital. I think it might be the oldest and referral cancer institute in Iran, that we have subspecialty in our hospital, in Cancer Institute Hospital. It means that we have professors assigned for different part of the body. Some of them review microscopic slides of head and neck region. Some of them are assigned for breast cancers, and some of them for GI. And it is a great honor for me to be a member of this team. Also, it is a great pleasure for me to be a member of a very experienced team in Danish Path Lab, which is one of the oldest private path lab in Iran. Okay, let's get started. The outline of my presentation is an introduction to oral potentially malignant lesions and oral epithelial dysplasia. And also we will take a quick look at the oral epithelial dysplasia grading systems. And after that, I will try to introduce 3 challenging topics in oral epithelial dysplasia. And also we will review therapeutic approach to oral epithelial dysplasia, which will be practical for clinicians. And also we will have an introduction to oral squamous cell carcinoma, unfortunately the most common cancer of the oral cavity, and it is very common in Iran, and I think in a lot of countries around the world. We will review the protocol for reporting cancer of the lip and oral cavity suggested by College of American Pathologists, and also we will review 8th edition of a staging manual. We will have a short review on histologic risk model, I think suggested by Professor Brandwein to evaluate oral squamous cell carcinoma meticulously. And we will have a short conclusion. Okay, oral potentially malignant lesions and oral epithelial dysplasia are very common in oral cavity. Unfortunately, this term is proposed by WHO workshop and replaced oral premalignant lesions and premalignant conditions in 2005. And also currently the accepted umbrella term to include all diseases, lesions, and microscopic changes that carry a risk transformation to squamous cell carcinoma. This term, oral potentially malignant lesions, including several, several lesions that more common, and some lesions that may not be as common as others. For example, proliferative verrucous leukopelakia, erythroplakia, oral mucous fibrosis, which is common in India, I think, and also erythroleukopelakia, granular thin leukopelakia, smokeless tobacco keratosis, and lichen planus, especially erosive forms. Let me ask a questions at this part of my presentation from the audience and the participants. Do you have any comment about the risk of malignant transformation of lichen planus. Do you have any experience? I will be grateful if you share your experience or knowledge with us. Zohra, can the audience turn on the microphone and share their ideas with us?
Yes, if they raise their hand, I can give them microphone.
Okay. Please raise your hand and share your experience with us. What do you think about lichen planus? Is it really an oral potentially malignant lesions or not? Professor Hill, do you want to get started? Yes, please.
Yes, yeah. So we do know that lichen planus actually is molecularly stable. In other words, there is no mutations that are taking place in lichen planus, and that is your ordinary lichen planus down to the erosive lichen planus. So there is actually, from the start, no indication that there is a risk for mutation into malignancy. Where lichen planus has been reported to transform into a malignancy is, for example, exposure to tobacco while the patient has active disease, especially the erosive form, where the tobacco carcinogens can much more and easily penetrate the eroded mucosa. And the other thing is that, and that is something that we are, a question that I have is the use of steroids, long-term use of steroids in treatment of lichen planus. Could that at some stage not be a risk factor for malignant transformation? But in itself, essentially, lichen planus is molecularly stable lesion. There is no evidence of any kind of pre-cancerous pre-cancerous mutational activity. But I think that where a lot of people may have made a diagnosis of cancer arising in lichen planus is that there may have not been true lichen planus lesion. There might have been lichenoid reactions to what already was an oral potentially malignant lesion. And I think tomorrow afternoon, somebody will talk about lichenoid lesions.
Great,
so,
yes, Dr. Sharabi.
Yeah, so I think that the protocol for diagnosing lichen planus must be absolutely watertight, clinically as well as histologically. And then I think that if there's no risk factors that are further added on, that there should be no reason to believe that it can become malignant. But that is, in general, every patient's got their own circumstances. And I've mentioned, if they continue to smoke, or what is the risk of long-term steroid application, because we know that can the inhibition to, for example, mutational or change in what normal basal cell keratinocyte might be taken away if you treat oral lichen planus continuously with steroids. And there are even some authors who have actually injected lichen steroids submucosally. And I think there's one or two examples where a lichen planus actually has transformed into a squamous cell carcinoma.
Thank you for your comment. You mean that, Professor Hill, that the injection of steroids may lead to malignant transformation of the lichen planus or squamous cell carcinoma?
There are some case reports. There are some anecdotes that the subcutaneous submucosal injection of steroids for lichen planus may actually not be a good thing, but why and how we actually don't know. But I'm still always warning patients to say, listen, we're going to treat you with steroids, but there is a risk that steroids may just be the fuel that you put on a burning field, and then you only have to have one match to light it all up. So that's the only risk that I can think about and then the smoking risk.
Great, thank you very much. I think we have Dr. Nandini. Do you have any comment? Nice to meet you. Do you have any experience about malignant transformation of the lichen planus, especially erosive form? In fact, I do agree with Professor Hill. I think it is not risk. There is no high risk for malignant transformation, especially the conventional type, reticular type, to transform to a oral squamous cell carcinoma. What do you think, Dr. Nandi?
I totally agree with Dr. Joss, but however, we did a study regarding the collagen fibers in lichen planus in comparison with carcinoma in situ, early invasive carcinoma, and normal buccal mucosa. And we found that there was collagen immaturity, similar to that of carcinoma in situ. So probably not just the epithelium, but the connective tissue factors also have to be taken into account in a later future studies, is what I feel like. And our study included, there were no erosive lichen planus. There was reticular and the other types, which showed some changes in the collagen morphology. You know? So I feel not only, I totally agree with Josh, unless there is a risk factor like tobacco habit or alcoholics, smoking and trauma or some inflammation, chronic inflammation, definitely it might convert. But hardly, there are 1 or 2 case reports which say that lichen planus carries increased risk of malignant transformation. So I think future studies have to be done to rule out the connective tissue nature of lichen planus. So that was an interesting finding. So our article is ahead of print. I can share the link later in the chat.
Okay, have you published the result of your study or not?
Yes, it is in the preprint in Journal of Ultrastructure and Microscopy. So,
okay, I will be grateful. I will be grateful if you share the link address of your study in the chat box with all participants. Thank you very much. Thank you very much for your comments. And if you would let's go to the next slides. The most common clinical presentation of the oral pre-malignant lesion or oral potentially malignant lesions are leukoplakia. You know that leukoplakia is a white mucosal patch or plaque that's not be characterized as any other lesion in oral cavity. For example, lichen planus, white sponge nevus, friction keratosis or other lesions like this. And also the other clinical presentation of oral epithelial dysplasia and also oral squamous cell carcinoma might be erythroplakia, that this lesion is also regarded as a red oral mucosal lesion that cannot be characterized as any other lesion in oral cavity. The worldwide prevalence rate of OPMLs ranges from 1 to 5%, and oral potentially malignant lesions is a clinical diagnosis, which histological diagnosis may be range from hyperkeratosis to oral squamous cell carcinoma. Therefore, it is recommended not to write leukoplakia or erythroplakia in diagnosis, but you can recommend these clinical terms in your comment in your path report. Recently, a scientific reports published by a team from Finland that they mentioned that oral epithelial dysplasia patients have about 44 times higher risk of developing oral squamous cell carcinoma than their healthy counterparts. And also the greatest risk is within 2 years of oral epithelial dysplasia diagnosis, And the important issue is about the women and more severe oral epithelial dysplasia grades also have a larger risk for development of oral squamous cell carcinoma. As you know, that dysplasia is actually means no more than abnormal or disordered growth. But in the context of epithelial dysplasia indicates a risk of malignant transformation. It is basically different from dysplasia of other parts of the body. For example, when you have a bone dysplasia, it is not at all a premalignant lesion. Epithelial dysplasia is identified by two changes, architectural and cytological. It is used to describe potentially malignant changes and is used similarly in colon and other sites. You know that WHO in 2017 published microscopic criteria for oral epithelial dysplasia in two different microscopic categories, architectural and also cellular changes. In architectural changes, you can see irregular epithelial stratification, loss of polarity, drop-shaped retroridges, increased number of mitotic figures, abnormal superficial mitosis, and dyskeratosis, and loss of polarity and keratin pair. And cellular changes including nuclear size, abnormal variation, nuclear size, nuclear shape, variation in cell size, cell shape, and increased N to C ratio, atypical mitotic figures, increased number and size of nucleoli, and hyperchromasia. In 2022, WHO microscopic criteria was revised, and there are several alterations that I will show you. Architectural changes altered. For example, increased number of mitotic figures moved from the architectural changes to cytological features. Also, abnormal superficial mitosis changed to mitosis high in epithelium. Premature keratinization in single cells moved to the cellular changes and replaced by generalized premature keratinization. And also some criteria were added to the microscopic criteria of oral epithelial dysplasia. For example, altered keratin pattern for oral subside, verrucous or papillary architecture, extension of changes to salivary gland. It's very important, I think. Sharply defined margins to changes, multifocal or skip lesion, expanded proliferative counterpart, budding and clustering at the, at the tip of the retroridges are very important, and also single cell keratinization in cytologic changes, and also apoptotic mitosis, increased nuclear size. You can see some of these cytologic changes here. For example, you can see an atypical mitotic figure here, an increased number of mitosis here, increased nuclear to cytoplasmic ratio is evident here, and also most of the keratin epithelial cells show prominent nucleoli. And also you can see here architectural changes, including elongated bulbous retroridges, scattered dyskeratosis within the full thickness of the epithelium, and it is all prominent. This is a very interesting image. I took it from a patient a few weeks ago, that you can see here a full thickness of cytologic changes involve the epithelium at the left side, and layer which is covered by you know, keratin layer. And the other photomicrograph shows that the elongated ureter ridges, but it is not as bulbous as the earlier one. But you can see here increase the you can see here the number of the basal cells at the tip of the you know, we can see here at the tip of the ureter ridges. I can call it as the low-grade dysplasia. Another important issue that you can use IC study for Ki67 as a helpful marker to assess the extension of proliferative activity of the epithelial cells through the epithelium. Okay, let's have your idea again from the audience. Do you have any idea about grading system, and which grading system do you commonly use in your center? I will be grateful if I have your comments. I think we have Dr. Nasser. Professor Nasser, do you have my voice?
Dr. Gandhi just raised his hand to talk, I guess.
Dr. Gandhi, pleasure to have your comments. Gandhi, I don't have your voice. I cannot hear you. And how about Professor Nasser?
He said that I cannot unmute. I think they have to give him the access.
Zohra, would you please help Professor Nasser to unmute? Zohra, could you please help him?
As Dr. Nandini wrote, they're actually mild, moderate, severe.
Okay.
Grading system.
Great.
But
and
yes,
other...
binary system is, I think, can be applicable, more applicable, because the moderate is something that we cannot decide on it. So maybe the low grade and high grade, in my opinion, is a better one.
Okay, great. So let me go ahead to this part of my presentation. As Dr. Gandhi explained, that we have a three-tier grading system for oral epithelial dysplasia. Anyway, we have several grading systems in the literature from 1969, which was introduced by Smith and also Pindborg. And at the moment, we have two grading systems: binary system, which has been introduced by Dr. Omar Kujan in 2006, and also WHO classification, the three-tier grading system. Three-tier grading system, including mild dysplasia, in which architectural disturbance limited to the lower third of the epithelium accompanied by cytologic atypia. And after that, we have moderate dysplasia, in which architectural disturbance extending into middle third of the epithelium. However, the consideration of the degree of cytologic atypia may require upgrading. Severe dysplasia means that we have greater than 2/3 of the epithelium showing architectural disturbance with associated cytologic atypia. The other grading system, as I mentioned earlier, is binary system, including low risk, in which we have less than 4 architectural changes, and less than 5 cytological changes. And the high risk in that we have at least 4 architectural changes and 5 cytological changes. If we have a comparison between a double-H grading system and binary system, mild dysplasia is always assigned as low-grade dysplasia, and severe dysplasia is always assigned as high-grade dysplasia. But we are supposed to identify if moderate epithelial dysplasia should be classified as low-grade or high-grade. It means that, as Arghavan will explain, that double-H grading system, including mild, moderate, severe dysplasia, is more practical at the moment in most centers. But it means that low-grade and high-grade dysplasia might be feasible to connect clinicians to the pathologist, and it should be considered in all centers. As take-home messages in this part, a biopsy negative for dysplasia does not exclude an oral potentially malignant lesion patients without dysplasia, but with clinical evidence of OPML should be offered entry into a follow-up protocol. And it is very important to follow up your patients who are suffering from epithelial dysplasia. The other important issue, including biopsy with an unexpected negative result, should be trigger further biopsy if abnormal mucosa is present. When I talk about abnormal mucosa, I'm talking about the clinical presentation of leukopelakia or erythroplakia. Dysplasia at one site in the oral cavity indicates increased risk of carcinoma elsewhere in the oral cavity. And also we sometimes face with candida infection, which is a confounding factor in dysplasia diagnosis and is best eliminated for accurate dysplasia grading. The finding dysplasia in child or young adult is very rare and warrants investigation for an underlying disorder such as Fanconi anemia. Although, nevertheless, in our center in Cancer Institute Hospital, unfortunately, we had several cases of oral squamous cell carcinoma and also dysplasia in young adults with no evidence of underlying systemic diseases. The term carcinoma in situ in the oral cavity is not recommended, and it is recommended to replace by severe epithelial dysplasia. And also, as I mentioned earlier, the proliferative fraction revealed by Ki67 immunostaining is a useful marker for upward expansion of the proliferative compartment. Okay, let me introduce 3 challenging, recently introduced topics, including dysplasia with lichenoid immune response, differentiated dysplasia, and HPV-associated oral epithelial dysplasia. And again, let me ask the audience, do you have any experience or any knowledge about these topics, especially differentiated dysplasia? Have you ever heard about these topics, these entities? No answer?
You're saying that a lot of unexplained changes, still basal cell hyperplasia, mild dysplasia, lichenoid dysplasia, HPV-related dysplasia. I think the clinical context is really important for lichen planus. As you said about the papillomatosis or verruciform appearance in lichenoid mucositis. It's something that we are not expecting. So maybe it's something as an oral epithelial dysplasia instead of lichen planus. So we have to, as we're asking the clinicians in bone lesions that we need a radiograph, I think for the mucositis and all these epithelial dysplasia, we need a clinical appearance also. This will guide us, the pathologists, to have a better diagnosis instead of just checking the histopathology and a description from the clinician.
You're definitely right. I do agree that clinical pathology correlation is very important and crucial to make a reliable diagnosis in these lesions. Okay, let's go ahead. You know, dysplasia with lichenoid immune response is recommended that it is better to forget lichenoid dysplasia, and it is recommended not to be used anymore. And pathologists should diagnose all oral epithelial dysplastic lesions with a lichenoid immune response as dysplasia, unless, as Argawan will explain, that clinical pathology correlation is in favor of oral lichen planus. Let's have a look at these two photomicrographs that in these, you know, microscopic features, basal cell degeneration and destruction of basal cells are very important to make a definite diagnosis. Destruction of the basal cells in lichen planus induces a number of changes, including generalized early keratinization around the, you know, the destructed basal cells, and also large precal cells, nuclei with prominent eosinophilic nucleoli and lying in the basal cells. Therefore, if you can detect, if you can find the destructed basal cell, it is very prone to make a definite diagnosis of, you know, lichen planus. But at the absence of liquefaction degeneration, a mixed cellular lichenoid infiltrate, cellular pleomorphism, altered nuclear cytoplasmic ratio, which are conventional features, are of dysplasia. Therefore, I recommend you to detect and scan the basal and parabasal layer to identify if there is any destruction of basal cells or not. Also, regarding differentiated oral epithelial dysplasia, it is characterized by a basal layer of small cells with hyperchromatic or open nuclei with a small nucleoli with an abrupt transition to suprabasal large cells with abundant eosinophilic cytoplasm with differences in eosinophilia and intercellular edema. It means that when you don't have enough cellular atypia, not only at the basal and parabasal layer, but also at the whole thickness of the epithelium, but you have some kind of architectural changes. As I mentioned earlier, differentiated dysplasia should be considered. It is important to know that differentiated dysplasia is not a separate entity, but this lesion is a part of the spectrum of the normal mucosa to severe epithelial dysplasia, but it is very close to normal tissue. Another term that earlier Amir talked about it, HPV-associated oral epithelial dysplasia. The hallmark of HPV-associated dysplasia is the presence of karyorectic cells, mitozoid and apoptotic bodies, often scattered throughout the full thickness of the epithelium. Also, acanthosis is also common, and the suprabasal keratinocytes may change orientation to lie at the right angles to the surface. You can see the microscopic criteria of the HPV-associated oral epithelial dysplasia proposed by Eddie Odell and his colleagues. Usually half to full thickness of the epithelium affected by the epithelial dysplasia and cytologic changes, uniform replacement of most epithelial thickness by cells of basaloid or lower precal cell morphology, loss of demarcation between basal and precal cells, acanthosis, increased mitosis, and others are the main microscopic features of the HPV-associated oral epithelial dysplasia. But it is very important to detect these lesions using P16 by IHC study and also ISH study, and it is necessary to make a definite diagnosis. And let's go to the next section of my presentation about therapeutic approach for oral epithelial dysplasia. I would like to invite the participants again. What do you think about the therapeutic approach for oral epithelial dysplasia? If you have, if you are working at your office and you have a path report of incisional biopsy of oral mucosa of your patient, and the diagnosis is mild epithelial dysplasia, what do you do for the patient? And if you have moderate epithelial dysplasia, how do you plan your therapeutic approach for the patient? And how about severe epithelial dysplasia? Okay, do you have any comments? Again, Dr. Etebarian, you are.
Actually, I think the follow-up is really important, or the rebiopsy.
For all of the patients, for all, you mean for severe epithelial dysplasia, moderate?
No. For the mild, I think we have to add a note, a close follow-up, and also a rebiopsy, maybe to check the other parts of the specimen. If it's an incisional biopsy, and a close follow-up, short-term checking, and these are the important, I think, and especially if it's a leukoplakia with oral epithelial dysplasia, because sometimes they are not localized and they're in a lot of areas, so the patient has to be under the close follow-up.
Okay, great. Professor Just, do you have any comment?
Are you asking me?
Yes.
I was just typing that for hyperkeratosis without cellular atypia, which is actually part of the spectrum now, to what we would call mild dysplasia, I would say one needs to look at the elimination of the risk factors. And if obviously there's no, let's say, compliance of the patient with the risk factors like smoking or alcohol, or that, for example, the traumatic origin of perhaps what could be just hyperkeratosis is not eliminated, then the patient needs to be followed up, as was suggested earlier, and that include maybe just a lower part of the moderate dysplasia, but for high-risk lesions, I advocate excision, laser excision.
Okay, thank you. I think Dr. Gandhi, do you have any comment? I cannot, the connection, the quality of your connection is very poor, Dr. Gandhi. Okay, let's go ahead and we will get back to Dr. Gandhi later. You know that the management algorithm for the cases of oral epithelial dysplasia proposed by the Liverpool multidisciplinary team. According to this algorithm, at the first step, you are supposed to make a biopsy, incisional biopsy. If you have a dysplasia, as Professor just well explained, that you are supposed to divide it into two groups, lower risk lesion and a higher risk lesion, regarding some clinical factors, including smoking status, gender, size. If you have a lower risk lesion, routine monitoring, including clinical exam, photography, and 6 month, monitoring of the patient for first year, and the yearly monitoring of the patient for 4 years is highly recommended. If you have a higher risk lesion, it is recommended to resect the lesion and monitor the patient every 3 months. It is proposed by Liverpool multidisciplinary team. And another, proposal for the clinical management of oral epithelial dysplasia is in mild epithelial dysplasia, you can divide it into low suspicion and also high suspicion. In low suspicion, conservative management, and the high suspicion, excision or laser ablation is recommended, and review for every 6 months for first year and then yearly. And for moderate epithelial dysplasia, excision with less than 2 millimeter margin is recommended. And for severe oral epithelial dysplasia, it is recommended to excise the lesion with 5 millimeter surgical margin. Okay, let's go ahead to I think we have about 15 minutes to 20 minutes, and let's go to oral squamous cell carcinoma. You know that it is the 16th most common cancer worldwide. It is approximately 94% of all oral malignancies of the oral cavity. The risk of intraoral cancer increases with increasing age, especially for males. The cause of oral squamous cell carcinoma is multifactorial. Intrinsic factors and also extrinsic factors are presented for the etiology of this cancer. Extrinsic factors including tobacco, smoke, and alcohol, and intrinsic factor including iron deficiency anemia. There may be distinct differences between head and neck cancers that develop in smokers comparing with those that develop in non-smokers, and it is well established that alcohol in combination with tobacco is a significant risk factor for oral cancer development. It is dose dependent and also time dependent. And HPV is introduced as oncogenic virus in in initiation, also progression of oral squamous cell carcinoma. Let me share a case of a 61-year-old female with you, a case of leukoplakia on lateral border of her tongue for 2 months duration and no significant past medical history. At the first incisional biopsy, you can see here at the photomicrographs and with higher magnification, you can see here that prominent cellular alteration extending from the basal cells to the surface. You can see here prominent significant increased nuclear to cytoplasmic ratio, loss of polarity of basal cells, and also dyskeratosis at high level of the epithelium. At the first, look, you can make a diagnosis of severe epithelial dysplasia. But what's the next step? What do you think about it? Do you prefer to have IC study of the case, rebiopsy, more cut sections, or you recommend to have a surgical excision of the lesion? Do you have any comment? Please send your comments in the chat box. Great, more cut sections. Serial sections. Yes, exactly. Thank you. And one of our colleagues suggests a surgical excision. I think for severe epithelial dysplasia, it makes sense, but please be careful. Yes, I recommend more cut sections because after cut sections, you can see here a huge nest of invasive carcinoma invading to the underlying connective tissue, even invading among muscular bundles. Therefore, in specimens show severe epithelial dysplasia, preparing more sections to rule out invasive carcinoma is mandatory. Please think about recommending rebiopsy if you are suspicious for a squamous cell carcinoma. On moderate epithelial dysplasia, make decision based on clinical pathologic correlation, as well mentioned earlier. Okay, let's go to the next section, protocol for reporting cancers of lip and oral cavity, suggested by College of American Pathologists. You can see here it is updated several months ago in 2021, November. You are supposed to report oral squamous cell carcinoma when you have an excisional biopsy. According to this report, you're supposed to report tumor focality, tumor site, and also laterality, tumor size. You are supposed to designate the architectural type, histologic type of the lesion, and also histologic grade, tumor depth of invasion, lymphovascular invasion, perineural invasion. Worst pattern of invasion is optional. Margin status, and also the status of the lymph nodes. Let's go to some important issue. The first one is about surgical margins. Commonly used cut points to define closed margins are 5 millimeter in general, and 2 millimeter with respect to glottic larynx. The final margin status then becomes a multidisciplinary integration of these findings. Therefore, I highly recommend you to be in close touch with the clinicians and the surgeons of your centers. It means that this is a judgment call that requires close interaction between the surgeon and pathologist. Mild dysplasia at a margin is considered as low risk and negative, while severe dysplasia at the margin is considered as high risk and positive. Regarding moderate dysplasia, College of American Pathologists suggests that at the margin implies an intermediate risk and is reported as positive. But we have several articles during recent years that the previous universally followed 5 millimeter margins have become arbitrary, and we need to relook the optimal distance in different sides of the head and neck. Understanding that margin disturbance, it is suggested in this article that we can consider group 1 from 0 to 2 millimeter as positive, group 2 as 2.1 to 7.6 7 as close, and more than 7.6 millimeter as adequate for accurate prognostication. Regarding tumor extension in College of American Pathologists template to report oral squamous cell carcinoma, extension to bone is very important to be reported, but you should consider that just invasion to the cortical bone is not enough to report bone invasion, and it is necessary to identify the tumoral nests within the bone tissue. And also regarding histology grade, a Brine grading system is very familiar, and you have 5 different criterion to assess the oral squamous cell carcinoma for histology grade, including degree of keratinization, nuclear polymorphism, number of mitosis, pattern of invasion, lymphocytic infiltration, and you can scale it as well, moderate or poorly differentiated oral squamous cell carcinoma. And it is very important to report histology grade of a squamous cell carcinoma. You can see here a well-differentiated squamous cell carcinoma on the left side with prominent keratinization, and there is no significant nuclear and cellular polymorphism. And the other side, at the right side, you can see moderately differentiated squamous cell carcinoma with the little foci of keratinization. When you have the poorly differentiated squamous cell carcinoma, sometimes you cannot make a definite diagnosis using just H&E staining, and you're supposed to use IC study, for example, pancytokeratin and also P63 to make a definite diagnosis of a poorly differentiated squamous cell carcinoma. Regarding other adverse pathologic features, it is very important to report all these features, as I mentioned earlier, including bone invasion and also perineural invasion, lymphovascular invasion, because it has a great impact on the post-operative radiotherapy. According to this paper, if you have more than one adverse pathologic features, it means that patients post-operative radiotherapy will be helpful for the patients. Okay, at the other part of my presentation, we will review 8th edition of a staging, especially T category depth of invasion. Depth of invasion was introduced in 2014 by a consortium focusing on head and neck cancer, suggested that depth of invasion is a better predictive parameter than tumor thickness. For every 5 millimeter increase in depth of invasion, pathologic T staging will increase 1 level according to the following: less than 5 millimeter, more than 5, but less than 10 millimeter, and more than 10 millimeter. You can see here when you have a tumor less than 2 centimeter and less than 5 millimeter for depth of invasion, you have a T1 stage. And when you have a T2 stage, you have a tumor less than 2, but more depth of invasion more than 5, or you have a more than 5 and less than 10 millimeter. And when you have a tumor more than 2 centimeter as a tumor size, you have and have a depth of invasion less than 10 millimeters, you have a T2. And T3 more than 4 centimeter and more than 10 millimeter, and T4 is classified as A and B according to the local or advanced invasion to the adjacent normal tissue. As you see here, to measure the depth of invasion, you're supposed to draw a horizontal line, then a plump line to the invasive front. You can see a comparison between the depth of invasion and also the tumor thickness. But during recent months, several challenges arise. If accurate horizon calculation is not possible due to angulation of the mucosa, as you see here, it is appropriate and more consistent to record the tumor thickness from the surface to the tumor. It seems that in complicated cases or angulated cases, it is recommended to replace depth of invasion by tumor thickness. And also, some other researchers suggested that we can recommend consensus for depth of invasion in at least some cases in which potential differences in depth of invasion could alter pathologic T staging. And also some others propose to replace depth of invasion, a complicated measurement with many challenges, with tumor thickness in the pathologic T staging system. And the other criticism on this depth of invasion measurement is that AJCC is silent about depth of invasion more than 2 millimeters, and there is no difference between depth of invasion from 10 to 20 millimeters and more than 20 millimeters. And at the last part of my presentation, I would like to introduce histologic risk model as a useful tool to assess risk of recurrence and death. It is, introduced by Professor Brandwein, as he proposed that resection margin status alone is not an independent predictor and cannot be the sole variable in the decision-making process regarding adjuvant radiation therapy or not. They suggested that the recommendation for adjuvant radiation therapy should be based on not only traditional factors, but also histologic risk model. This model including worst pattern of invasion, lymphocyte host response, and perneural invasion. You can see here that how they scale these variables. AJCC and also College of American Pathologists accepted pattern of invasion as an important criterion that should be reported in path reports. But the important issue that is just pattern of invasion 5, in which that you have a satellite at least 1 millimeter away from the main tumor is important, and other worst pattern of invasion are the same. And finally, as we talked about it with Amir earlier, several case reports have been published that human papillomavirus associated oral squamous cell carcinoma might be an entity with distinct morphology and clinical features. It might be in situ or invasive, microscopic features including basaloid cells with distinct cell borders, lack of intercellular breach, and increased N to C ratio, and P16 positive using IHC study, and high risk HPV positive using each is mandatory to make a definite diagnosis of HPV associated oral squamous cell carcinoma. And as a conclusion, oral pathologists have a crucial role to make a definite diagnosis of incisional biopsy and also excisional biopsy. They are supposed to prepare several recut to detect invasiveness, and also they are supposed to provide well-descriptive path reports. I recommend to use College of American Pathologists template to provide a well-descriptive report for the clinicians, especially surgeons. Okay, thank you very much for your kind attention and ready to answer any questions.
Thanks, Dr. Shakib. That was a very thorough presentation and touching the important points on this challenging topic. We have a few questions in the chat box. The first one is from Dr. Safar. She's asking that, can you explain how to differentiate dysplasia from pseudoepitheliomatous hyperplasia?
Yes, thank you for the important questions. In pseudoepitheliomatous hyperplasia, we don't have any architectural changes of the epithelial dysplasia. And also we have bland looking cells at the basal and parabasal layer. In spite of the pseudoepitheliomatous hyperplasia, in differentiated dysplasia, we have some cytologic change in basal and parabasal layer of the epithelium. And also elongated bulbous rete ridges are sometimes detected in differentiated dysplasia.
Yes, thank you very much. Dr. Afifi asked, what is the difference between dysplastic lichen planus and dysplasia with lichenoid reaction?
You know, as well mentioned and talked about it, that clinical pathology correlation is very, very important to make a definite diagnosis of a lichenoid reaction or dysplasia with lichenoid immune response, or you know, a lichen planus. Therefore, at the first step, I recommend to have a clinical, a comprehensive clinical data of your patient, and also meticulous evaluation of the microscopic slides, especially focusing on the basal parabasal layer to detect hydropic degeneration of the basal cells. A combination of all of these data might be helpful to make a definite diagnosis. Also, I would like to invite you all to join our tomorrow meeting. I know that Professor Shahrabi Shokoufe will have a great presentation focusing on lichenoid lesions.
Yes, that's terrific. Dr. Abdullah asks that one of our frustrating experiences in our lab is differentiating genuine dysplasia from inflammatory atypia. Can you please elaborate on the topic?
It's very challenging to differentiate a reactive atypia, cellular atypia, in response to diffuse severe inflammatory infiltration at the superficial connective tissue, and a true dysplasia. I think it's based on a combination of the architectural and cytologic changes. I recommend you to include all cytologic alteration of the epithelium introduced by WHO classification to differentiate these two lesions.
Yes, thank you very much. Dr. Nasser wants to talk actually, but
sure,
I don't know if he has access or not. I have asked the IT group to unmute him. I think he has raised his hand, or is there anything that we can do to give him the access?
I think Zohra can unmute him.
Dr. Nasser.
Yes, if he can start his video, I can I can detect him and give him a microphone.
Professor
Okay,
Nasser.
okay.
Oh, I am unmuted. It's a miracle. I've been trying
hello. Nice to meet you.
Professor Porian, this is a great presentation, one of the best actually.
Thank you very much.
I have comments about a few comments that I wanted to make. First, about lichen planus. I believe it's
I really believe it's a pre-malignant potential, or at least a pre-malignant condition from experience. And if you look at the literature with the Silverman original reports from San Francisco, and my follow-up of lesions that are classic lichen planus, not lichen planus with immune response, that turned into malignancy with follow-up, I believe it's a very dangerous lesion and should not be ignored. As far as the grading of dysplasia, whether you believe it's in this step proliferation from a mild, moderate to severe to invasive, or even the mild dysplasia can turn into invasive cancer. That's an important distinction with, like Piotrli said, the clinical pathology correlation to make sure that this is covered with the thick leukoplakia versus thin leukoplakia, erythroplakia, red and white, etc. That makes a difference in how you titrate the follow-up. It's important to how to customize that patient's follow-up and eliminate lesions versus multiple biopsies, especially if you don't want to miss a PVL. That's important. But I really agree with you 100%. With the grading system is important, as well as the histology. But to me, the elimination of the lesion from the beginning with clear margins makes a lot of difference in any dysplastic lesions. Better than missing the lesion, or the patient lost it to follow-up, and then you won't be able to continue to see this lesion for progress. So these are my two comments. The lichen planus versus lichenoid dysplasia, I agree with you. Lichenoid dysplasia is a very tricky, slippery diagnosis to make, because there's a lot of overlap between what is lichen planus and what is the epithelial tropism versus the immune response, the basement membrane intact or not, the liquefactive changes of the basement membrane. These are all important features. However, there are areas where you're going to see overlap. And, as long as you rule out candida, you rule out inflammatory related atypia, there's a lot of overlap in those situations. And to me, really the most important thing is the follow-up to see if the lesion doesn't look right. It has to be eliminated and continue to follow up the patient. But that's all I wanted to say. I apologize for taking too long. And thank you for unmuting me. This means a lot. Appreciate you.
Great comments. Thank you.
Thanks, Dr. Nasser. I think we're done with the questions in the chat box, but if there are any questions or comments
I think
left?
Dr. Nandini.
Hello, Dr. Kuyan. I just wanted to ask you, I just wanted to ask you regarding the case of OSMF with leukoplakia. I mean, there is a clear white patch. So have you come across like hybrid lesions like OSMF with lichen planus or OSMF with leukoplakia? In that case, the bulbous retipex and all those features are not there if there is a leukoplakia in OSMF case. So have you come across the difficulty in such cases, like hybrid cases?
You mean oral submucous fibrosis in combination with?
And clinical, yes, there is a severe OSMF, and in combination with that, there is a white patch. Clinically clear hyperplastic white patch was there. So in that case, the leukoplakia for the grading, bulbous retipex and all those are not seen. So in that case, have you come across similar cases in your reporting?
There's
a combination of lesions there.
Yes. In fact, I don't have several cases of combination of leukoplakia, oral submucous fibrosis. In fact, it is not a very common lesion in Iran, although I know that in some parts of Iran, especially I think, then I think that's south of Iran, we have cases of submucous fibrosis, but it is not very common and we don't have such combinations in our center. But I will be very grateful if you would share your experiences with us.
Yeah, sure. And one more thing is OSMF with verrucous hyperplasia. You know, those lesions have been very frequently reported nowadays in India. That is also one more hybrid lesion, like which we need to see for. So these are all coming under oral potentially malignant disorders now.
But I think it is more common in India. You know,
Yes.
Smoking tobacco is very common in Iran. Chewing tobacco is not very common. And
yes.
I think
especially oral submucous fibrosis. So because lots of cases are turning into the hybrid, into carcinomatous changes and some verrucous hyperplasia, some into leukoplakia and so on. So combination of habits is giving multiple clinical presentations.
Yes, sorry, I don't have enough experience about this combination, especially oral submucous fibrosis. But I would like to invite other professors, Professor Nasser, Professor Jos, Dr. Tebarian. Do you have any comment about Dr. Nandini's questions? No comment?
About verrucous hyperplasia, it actually was originally distinguished from verrucous carcinoma as two separate entities. But I think nowadays, when we see verrucous hyperplasia in a patient that has got habits, like smoking or alcohol or whatever, I think it needs to be seen also as a potentially malignant or pre-malignant lesion. And we know that keratosis, especially when it's got verrucous appearance, you can call it an atypical squamous lesion or proliferation, but I think it has got a connotation to be either excised or watched. But watching, I'm not very in favor of watching, especially when there's bad habits. And it can be part of the spectrum of proliferative verrucous leukoplakia.
Okay.
Thanks, Professor Hill. Okay, Dr. Nasser wants to talk, I guess. Can you unmute him? Ms. Zohra, please.
Yeah. Okay, thank you very much. I see submucosal fibrosis here in the States as clinical consults in immigrants mainly, mainly India, Vietnamese, Southeast Asians that are immigrants to the States, and I agree with Dr. Healy. There's overlap with the PVL, especially in the early stages, and they do turn into malignancy regarding what you do, whether you stop it or not. It is a one-way street compared to smokeless tobacco, for example. But the proliferative hyperplasia is a very again, it's a spectrum of the lesion. As long as you're not missing a papillary squamous cell carcinoma, I like to evaluate the basement membrane, intact status of the basement membrane, and allow room for the kind of a pseudo epithelial hyperplasia features within the lesion to really differentiate it from true dysplastic lesion versus just a hyperplastic lesion. And that sort of help with the curtain plugging versus basement membrane intact versus the broad margins that you talked about beautifully, and other features histologically. Plus, the main thing is you want to not also forget about the old verrucous carcinoma. That's a very important part of the spectrum. That's a lot of time forgotten, or at least taken a much lesser importance in the newer a WHO classification as I see it, but that's another lesion that has to be kept in mind all the time.
Thanks, Dr. Nasser, for adding your comment on this. So if there aren't any further questions, we can actually show Dr. Shakib's certificate for this great presentation. And then we can ask all the attendees to turn on their camera. Yes, thank you, Dr. Shakib.
Thank you very much.
So that we can have a memory photo of this event as a great memory. So I would like to ask all the attendees to turn on their camera. Yes, thank you very much for being here.
Let's wait a few seconds more.
Okay.
Okay, great.
So the IT group has just taken the photo. Yeah. I guess.
Yes, we are waiting for others to start the video.
Okay. If they like, they can turn on their camera. Very good.
Great.
So once again, I would like to thank all the attendees for your interest and attention, and also our great speakers, the organizing committee, for making this a great Congress. So if there aren't any comments or questions, I wish you a very good morning or good evening, and we'll see you all tomorrow.
See you all tomorrow.
Tomorrow, yes, tomorrow for our second day.
Have a nice day. Bye-bye.
Have a great day, everyone. Be happy and healthy.